Hi, Assalamu alaikum. My name is Dr. Adnan. I'm a general surgeon resident at Sheikh Zayed Hospital, Rahim Khan. Today, the clinical vignette and the topic I'm going to present is as follows. An 8-year-old boy presents with severe abdominal pain and repeated vomiting for 24 hours. The pain started in the upper abdomen and has progressively worsened. There is no history of fever or diarrhea. On examination, the child is tachycardic and dehydrated. His abdomen is mildly distended with marked upper abdominal tenderness and guarding. Bowel sounds are sluggish. An abdominal X-ray shows a localized ileus in the upper abdomen. What is your differential diagnosis? What would be your next investigation? This vignette loosely points to intestinal obstruction, but the important landmark here is tenderness in the upper abdomen and guarding. An 8-year-old boy can present with intestinal obstruction, but these signs may point towards an a pathology in this region of abdomen like pancreatitis. So my investigation of choice here would be serum amylase or lipase. So the topic of discussion today is pancreatitis. We start with the anatomy. Pancreas is derived from the Greek word pan, meaning all, and krios, meaning flesh. It was once considered just a cushion for the stomach, but later on it proved to be it was understood to be both an exocrine and an endocrine gland, which consists of head, body, and tail. It consists of two ducts in the 60% of population. A main duct, which is called the duct, as you can see here. At this point, this duct of Wirside supplies the pancreatic enzymes into the duodenum via major ampulla of Vater is a thickening the duodenum where the duct of Wirsing joins. And another duct, the accessory duct of Santorini. In normal 60% population, this duct is also present and drains into the duodenum via a minor papilla. Minor papilla and an ampulla of Vater is here as well. It's called minor papilla. Similarly here, a major papilla, minor papilla. So, two types of variations can exist in these ducts. In one, the accessory duct suppresses and only the main duct drains into the duodenum. And in another portion of population, the main duct suppresses or joins the accessory, which drains into the duodenum. And here, this is where the problem starts. Now, there is a sphincter on each duct called the sphincter of Oddi. Here you can see the surrounding structures and anatomical relations of the pancreas. On the right, you have right kidney. On the left, you have spleen, where the tail of pancreas ends. Superior surface of pancreas, there is an artery, the splenic artery, and posteriorly the splenic vein and the inferior mesenteric vein join to form portal vein, which at the level of neck of the pancreas runs upwards to join the porta hepatis. Pardon me, superior mesenteric vein and splenic vein join to form. From the head, there is this process called the uncinate process protruding medially, at which point these vessels turn behind the pancreas. It's important to understand the embryology of the pancreas in order to gain complete understanding of this pathology, especially in pediatric pancreas develops from two birds, the ventral bud and the dorsal bud. You can see here, this is the ventral bud of the pancreas, label C, and D, the dorsal. And an important uh, development that happens here is the rotation of the ventral bud, which goes across and comes posteriorly and joins the dorsal bud. This ventral bud joining the dorsal bud forms the head and the uncinate process. And also, the duct of Wirsung is located in this ventral bud. So, whenever the pathology occurs, suppose there is no rotation or malrotation, and the ventral bud fails to join the dorsal bud. This is a condition, uh, as we will discuss, called as pancreas division. Then the majority of the pancreas secretions are drained via the minor duct of centrorenal accessory duct, which puts pressure on it on the drainage system, resultant obstruction.